We'll go ahead and get started. And this is the Patient Illness Experience course. And I recognize that for many of you, this is your last semester in the program. Yes. You're really here. I remember the first semester when you just joined us. So for those of you who don't know me, I'm Kathleen Rayman. I'm the Director of Graduate Programs. I know many of you, but not everybody. I guess first of all, if we pick when is a good time during the week for people to have a synchronous meeting? That's probably our first thing. So if we do a Thursday evening, and what if we start at 5:30? Would that give people enough time to kind of get home and get settled and find some quiet spot? 5:30? And if you'll just reserve 5:30 to 8:30, sometimes we use the whole 3 hours, sometimes we don't. But that seems to be a typical, reasonable amount of time. So if we do Thursdays from 5:30 to 8:30, and we already know that our last class week, we're going to have a synchronous session. So that will be the week of, let's see, the 28th of April. So what is a Thursday? Does someone have a calendar? It's May 1st. Okay. Okay. So May 1st from 5:30 to 8:30. And then typically what we've done in the past is do at week 5 and week 10, because that kind of spaces things out over thirds of the semester. So if we did something around week 5, it would be the week of February 17th. Well, I'll tell you what we could do. This is always an option. If you're here on campus for that and you want to come here to class and meet here for your part of the synchronous session, that'd be fine.
Okay, so that's fine with me.
Yeah, so if we do it April the 3rd.
Okay.
At 5:30?
Yeah. And that's actually an option that we would have for any of the synchronous sessions. If you want to come here.
That's what I like to do because I'm a 2-year-old and he beats the door down.
Okay, that's fine.
Even if I walk it.
So you can either come here and we'll be on Adobe Connect for anybody who wants to do it remotely or needs to do it remotely. And that usually works out well because you have some people here around the table and then we interact with people at a distance. So it's your option in terms of what you want to do. So our dates are April the 3rd, well, we'll start February 13th from 5:30 to 8:30, April the 3rd, 5:30 to 8:30, and then May the 1st, 5:30 to 8:30, which is our last class day.
So, I'm sorry, I was trying to get there. So February 13th.
Mm-hmm. April the 3rd, and May the 1st, 5:30 to 8:30. You have the option of coming here on campus if you would like to, or you can participate remotely through Adobe Connect.
February 13th.
February 13th. So everybody's set on the dates now and the times. Okay, well, let's spend a little bit of time at the end of our time together thinking about what all we're going to talk about this semester. And really the content kind of divides itself into like 3 dimensions, and you'll see that from the syllabus. The first is patient perspective, illness experiences, and the body, like symptoms, and the meaning of symptoms. So those are the kinds of things in the first part that we're going to be dealing with. And the important role of narrative, or the telling of one's experience, and why that's critically important. And some of what you'll read, our authors tell us that for people, all of us, including our patients, things become real when they're told. So that's a part of the way that we construct personal meaning around events. And then there are many things that are important related to people's social role, to their gender, because all of that is a part of experiential knowledge. So that's the first dimension. The second part of what we're going to be studying this semester in the course are theories and attributions of illness. In other words, how are people making meaning or understanding their own experience of their illness? And what can we learn about that? And those are called explanatory models. So you'll read about that in Kleinman. And then the role of pain and suffering. So what purpose do those serve in people's experience? We think about pain as something that needs to be controlled. You know, as practitioners, it's something that's not good. But there are many, many other things about the experience of that are important to people in terms of how they, the meaning in their life, for example, if they get to a place where there isn't really any good answer for pain control, and maybe there's surgery, but maybe that's not a very good answer either. And so you kind of get to the end of the road where there aren't good answers. And we think about that in terms of therapeutic interventions because we have so many at our disposal in our culture and in Western medicine. We have a tremendous availability of therapeutic things at our disposal. Other cultures view all of this very differently. They don't have the technologies that we have. They don't have the resources. And they also don't have the cultural belief that people would be entitled to those kinds of resources because they simply don't exist. So there are different views about that. And then the third dimension of what we're studying has to do with professional and organizational considerations. So things like, we're talking about this importance of patients' voice in all of this throughout the course. How do we learn to privilege that? Or in other words, how can we allow that to be part of our practice and be an important part of patients' care? How can that happen? What are the recommendations? What are our thinking about that? How are there ways that we can invite patients to tell their stories within our practice, and how can you do that within the constraints of practice settings that we all know? You all are in those practice settings, completing your capstone and residency projects and hours and trying to learn clinical skills. And so how in the world do you incorporate these very important things, we believe they're important, into that practice, and how does that happen? What are the suggestions and changes that would need to happen to create more healing environments for patients? And then what kinds of supports are needed for staff, practitioners, patients, everything to make that happen? And I'll give you an example of a really interesting case study that was done pretty recently by someone who's a social anthropologist, and those are the people that are interested in these kinds of problems. And he was called in as a consultant to a large oncology practice in California because they had such terrible scores on patient satisfaction related to the wait times when patients came into the clinic. And they tried everything they could do to try to fix that, and they just could not get it fixed. So patients were waiting 2 hours, 3 hours, and you know, these are people who are debilitated, they're very ill, they have family members who are transporting them because they can't drive, and you know, all of that. You can picture this. So the health center called him in and said, we just have to have a different look at this because we can't solve this problem. And what he discovered when he studied it was probably those wait times couldn't really be changed because they were due to things like some kind of major emergency had come up with a patient. So it's not providers saying, here's what I think my patient needs, and I think they're pretty satisfied, and I've sort of determined what that looks like or what that needs to look like through a QI process. This is a very different view where patients are saying, this is what I need my provider to know about me, and this is what would help make my experience better because this is what the experience is like for me. And in my own area of diabetes self-management, this has been talked about and discussed for probably 15 years. And we've made some strides in really incorporating patient perspective, but I can tell you that in the main, we as providers still think, well, people have complications and they have problems. because they just don't do what we're telling them to do. And if they would just do that, then, you know, the rest of these things would just resolve themselves. And we don't really understand that what we're thinking they need to do is worlds apart in a lot of ways from what's possible for them based on a whole host of different kinds of things that have really nothing to do with compliance or adherence or, you know, the terms that we use that really give us an idea of how someone's care practices aligns with medical knowledge. So, if we're going to take a look at what patients have to say and what they can tell us and how that can inform how we decide we're going to be as practitioners, we could pretty well start to think differently, hopefully, about how we're going to evolve our practices as doctorally prepared people. So that's the focus of the course for this semester. The majority of the readings that we'll be doing don't come from the United States, because the majority of this work has come out of the United Kingdom and Canada, and some in the Scandinavian countries. So when I've been at conferences presenting, because my research is in illness experience of diabetes self-management, those presenters are from those other countries. And when United States researchers approach this, they generally are coming from a QI perspective, which is an absolutely useful and critical perspective, or a patient satisfaction perspective that looks at survey information based on particular kinds of experiences, usually within institutional settings. So the UK and Canadian researchers are really very interested in looking at how do we understand what's happening with patients, and then if we have that understanding from their perspective, how can we shape systems differently to provide care that's going to help address those kinds of issues for patients, and how can we rethink how we interact with people or how we shape our own practice perspectives based on that. So I think it's a great course for you all in your very last semester, because it'll help you really start to think beyond, you know, the institutional kinds of care and roles that you've had, and what might be possible with this doctoral degree in terms of thinking through how will I be different as a doctorally prepared practitioner, and how will people notice that? How will they know that I'm different? What might they notice? What would that look like? So from the beginning of the course, we're going to talk about the writing that's out there and the research that's out there about patient illness perspective from the patient's point of view, and then move into what are called explanatory models of illness, which come from the patient's perspective. And then I'll ask you to do some writing about a case, a patient that you've worked with, that you are thinking, that you want to think about and focus your work on this semester. So students in the past have picked a case that was sometimes particularly confusing to them, or particularly challenging, or something that you felt you just couldn't get right. It just didn't go well no matter what everybody did. So you might think about that, because usually when you go back and sort of unpeel the layers of that, looking back and having some theoretical basis to look at it differently, you start to see that person's perspective, of course, is what governs how we are in the world and how we care for ourselves or not. But if we're not even looking there when we're providing care in our pretty traditional ways that we've all been educated to do as nurses, as registered nurses, and for some of us as advanced nurse practitioners, you know, there's a misalignment. We're just sort of missing it. And we don't know that we're missing it because we just keep doing more of the same. We keep doing more of teaching. In my area, that's what we do. We say, well, that patient needs knowledge, because we have the assumption that if something's not happening, it's because they don't know. Well, sometimes they know a lot. Sometimes they know more than we do. But there are other reasons around why that isn't happening, and they're pretty deep reasons. They're not superficial kinds of things that you can just say, well, it's this and this and this, and so if we identify these barriers and get rid of them, then this will magically work itself out. Because if you think through your practice time, you can all think of certain patients that you've known who, no matter how many people tried to put their heads around a problem and tried to solve it or tried to make things better, it just didn't get any better. It didn't get much better. So I'm asking you to think about what we're calling a paradigm case in your practice, where there was something that happened that changed your thinking about how you practiced. So a patient who either interacted with you in a way, something that just really stuck with you, and you thought differently about how you practice based on that. So just be thinking about that as we're going along, because that will be your focus. So sometimes students have chosen a patient. The other option is if you or a loved one has had a significant illness and you want to focus on that, you have the choice to do that. And I've had students do that in the past too. Sometimes people have undergone some kind of traumatic event that they choose to focus on and do their work for the semester. Sometimes it's been a loved one who's been diagnosed with a terminal illness or a chronic illness. And so you know all the details. But the key is it needs to be a case where you know lots of stuff. So you can go back and really reflect on all the details that you know and then start to apply this new theory that you're going to be reading in the course to that particular setting. So if you don't know a lot of details, it's not going to be helpful to you, because you have to have a lot of depth to be able to do this. So just start thinking. Start thinking about those patients that you've had in the past that have been either a wonderful outcome or a very challenging kind of situation. Or sometimes it's a case where nobody else on the unit, I mean the whole unit was frustrated with something that happened or with a particular person who continues to come in. And with length of stay the way it is in the hospital, we don't see that as much as we used to. I mean, there used to be patients in my career as a young doctor, bachelor's prepared nurse, and I was working on a medical surgical floor, and there were patients who would come in particularly with chronic lung illnesses, and you could predict when they were going to be in the hospital. And you could predict if there was a stressful kind of situation in their family, something was going to set that off, and they would be in through the ER, and we would be seeing them. And those situations just became a revolving door. They never were resolved. No matter if social work was consulted, no matter whatever was going on there. You can throw all the resources at it, but it was not effective in terms of dealing with those kinds of things. So just start to think about how you want to focus your work for this semester. Might have something to do with your capstone project. I mean, if there's a situation there that comes to mind, because really the focus of this course is to be integrating the kinds of things you've learned in the program so far and to have a chance to really take a careful look at something and apply some new theory to it. So think about your practice, think about a paradigm case. So that's part of our work. We'll be doing that, and you can talk about your particular cases as we go along and applying those theories. So we have to learn some theories in order to apply them. And so I'm going to ask you now to go back to your theory course, which was way back. Remember that 2-credit course you took that everyone says, you know, the first semester, and people say, well, I'm glad that's over. I'm never going to talk about that again, and I'm going to sell my book and I'm going on to the next semester. Well, I'm asking you to go back and rethink a little bit about theoretical perspectives and to bring that knowledge forward in terms of looking at sets of ideas, because that's what we'll be doing. If you remember just a little recap of theory, what you have there is any kind of theory is a set of ideas. It's something that someone came up with. So, you know, different people are sort of famous for their sets of ideas because they publish them and they are written about, and then we teach them in programs, and so students learn them, and then that's how we understand different ways of creating knowledge and of using that kind of understanding to help our practice. In nursing, we have some that we talk about a lot, and there are those by people like Roy, Rogers, Oram, Benner, those are some of the familiar ones that I know you read about, Watson. So everybody kind of has one that resonates for them, and usually it's the one you presented on when you were in the theory class. That's the one you remember, which is a good thing because it helps you remember some of that stuff. So those kinds of sets of ideas in nursing, there are corollary sets of ideas in patient illness experience. And we're going to be reading some of those people who've written about those ideas. And one is Arthur Kleinman, who was a professor at Harvard, and he's written one of the books that we're going to read. And another is Arthur Frank, who's a Canadian anthropologist. And he's studied specifically patient illness experience, and he got interested in it because he had an experience of being diagnosed with cancer himself. So that's what got him really interested in the whole area of chronic illness and care, and the sort of disconnect and what that feels like to be diagnosed with a chronic illness yourself internally, if you really took a look at that. So some very compelling things that we'll be reading. So I'm going to ask you to do that. We'll look at those illness theories, and then we're going to try to take a step beyond that and say, okay, so if we know about these theories and we have some knowledge about what patients experience that's based in research, what would that mean in terms of health systems and my practice if I were trying to incorporate some of this? Would the patient experience be different, and how might it be different? So sort of imagine what that might be like. Make some projections, make some suggestions about changes or refining things in ways that would have us practice differently, and then particularly have patients have different kinds of outcomes. And this is all in the syllabus, so we'll be going over that in a bit here. But I wanted to just kind of give you the general landscape, because I think this is a really different kind of course than what you've taken before, most likely. So you'll be reading, thinking, doing some writing. We'll have some seminar time when we do our synchronous meetings, and that's pretty much the crux of it. Now, everybody's worried about their paradigm cases now, aren't you? Yeah, the first semester that I ever taught theory, in my very first academic position, I had some really pretty new graduates, like they had been out for 1 year, and we just changed the policy so they could come to a master's program. And so in the theory course, I would have students think about a paradigm case. And one student was very, very worried and nervous after the first class. She came up to me at break and she said, "Dr. Rayman, I don't have any paradigm cases. I'm just a new practitioner and I don't have any paradigm cases." Well, you do, believe me. We'll find a paradigm case. And you all are much more experienced than she was. But anyway, don't fret over that kind of thing, because you have lots of paradigm cases if you start to think about it. Well, anything you'd like to add to the course, or that you think would be helpful in terms of your own learning at this point? Because that first day is kind of negotiable as far as I'm concerned. I mean, I have a general direction that I would like us to go, and we've gone there in the past with this class and it's worked really well. But if there are things that come to you in terms of your thinking about it that you would like to add, or things that you think are important, please be sure and bring those up. Because where we go with this is really kind of collectively designed. People grow and change in ways that are different as a group than we do individually, which is the nice reason to have people together in a class. So if you look at the first page, it just gives you the general kinds of things that you see in any of our syllabi for the College of Nursing. And it gives you that the course is 3 credit hours. It has my contact information on there. And you can contact me at that email address, and then once we get the D2L site operational, of course there's email in through there too. We can do phone conferences if there's something that you need to talk with me about, and I do that often with students. So email is good. Sometimes it makes sense to just pick up the phone and have a conversation, because you can really kind of take care of things real easily and efficiently sometimes on the phone, rather than going back and forth with an email long string of things that sort of doesn't get clarified. So I'll let that up to you, but those are both good ways to get in touch with me. And in terms of the catalog description, the course really, in the course, we're going to look at the illness experience from the patient's vantage point. So that's probably a very different look, it usually ends up being. And we're going to look at distinguishing illness from disease. And I know you've learned a lot about disease processes in all of your courses in the FMP program and in the PMHMP program from a behavioral health and mental illness perspective, and then look at the role of narrative in enhancing healing relationships and environments, because that can be a particular part of your practice that you might want to think about. So what is the value, in other words, of patients being able to talk about what's going on with them, and how do we have understandings related to that? How do we find time in a practice setting to incorporate that or elicit it, and all those kinds of things? Because the challenges you're going to see right away are there's writing about how this happens and the best way for it to happen, but when you try to translate that into a clinical environment where you have caseloads and people that have crises and very busy kinds of things, it raises a lot of challenges. And also in practice settings where there are requirements about how many patients are seen, the length of time that you can spend with patients, and those kinds of things. So all of those will come up, and we'll wrestle with them as we go along, because there are no easy answers to any of it. Hi, John. Good to see you. We were just going over the syllabus. Whoops. Okay. So in terms of the course overview, the course looks at patient illness experiences. We look at cultural life course. What is it like to be disabled or chronicity? What's the meaning of those kinds of things? Aging and gender, because there are some writers that say there are lots of things about illness experience that are very gender specific. And so that's very interesting literature to look at and think about. And if your paradigm case that you're thinking about happens to be a woman or a man, you might start thinking in terms of gender and start just sort of keeping that in front of you as you're reading and wondering about their experience. And then how we can implement patient-centered care and settings that you're going to be into. And you're really in just the optimum place to be thinking about this kind of thing and doing it, because in some settings anyway, the DNP role is evolving. And it has yet to be really clearly defined, so you're the definers of the role. So you're in a wonderful position to be crafting that in a way that you really would like to practice as a doctorally prepared nurse. Okay, and I'm not going to read the outcomes to you. You can read those at your leisure. The topical outline, we'll be looking at symptoms and disorders from the perspective of patients' meanings of those, because it's very different than our meanings. You've studied lots about symptoms, and you've studied lots about the diagnostic process and how you arrive at diagnoses and so forth. And so our perspective in this course is going to be, what's that like for a patient to have that diagnosis applied to them? What does that mean? What does that feel like? And then illness as a social experience, roles of subjectivity and intersubjectivity in health and illness, and then the theories that are out there around chronic illness, and they're called explanatory models. What's the role of narrative as an approach in healing practice? If you're thinking about your role as a provider, how might that be rethought or refined? And then what are the challenges in trying to implement this kind of culture, a patient-centered culture, into an environment where we want people to be healing and progressing rather than simply being discharged and going on to the next thing. So we're going to be looking at some case analyses. We'll have some discussion forums that will be in D2L that are going to be asynchronous. And I'll just tell you in general, the way that works, there's one or two discussion questions that kind of focus the readings for the week. And that will open on Sunday night well, actually it's like Monday morning. According to the dates on the syllabus, they'll be open like at 12 a.m. on Sunday. And then you have to have posted your things by Saturday evening at midnight the next night, or 11:59 or something like that. So they're open for 1 week. Okay, and then we'll have 3 synchronous class sessions, the last of which is going to be the presentation of your integrative final paper, and we can do that in a synchronous way. Students have done that in the past and it worked out just fine. And then we'll have 2 other meetings where we'll meet in a synchronous session using Adobe Connect and have discussion on that week's topic. And then the written assignments. There's a midterm paper and a final paper. So there's some writing, there's a lot of thinking, there's some discussion. I guess that's one way to kind of summarize what we'll be doing together. And you can see how things are weighted. So the discussion participation is 20%, the midterm paper is 30%, and the final paper carries lots of weight in the course because you're going to be looking at carrying forward the work you do in the midterm case analysis with your paradigm case, and then applying those theories and making some recommendations in the final paper. So they're linked together. And the final paper is 30%, and then your presentation of that paper is 20%. So there's lots of weight on that end because that's where you see everything come together. The grading scale is the same grading scale that is in all of our courses, so that will look very familiar to you. And then I put down 2 required texts, Frank and Kleinman, and there are others that are recommended, Gertis, Morse, and Lorber, and I brought copies of all those so you can take a look at them today and see what you think, because sometimes you might want to share books, sometimes there are books that really pique your interest and you want that for your personal library, but it'll give you an idea of being able to see what the readings are like. And then there's the student procedure for special services, which is very familiar to you, I'm sure. And then the course requirements. This is the rubric that I use to grade both papers. And you can see how the various aspects are weighted. So scholarship is 25 points or 25%. And that means that you have really reviewed the published literature out there and or the readings from the course. So when you're writing, you should be making connections about those and they should show up in your paper. And I know you've done lots of writing in the program, so that will be something that you'll be pretty familiar with, I would imagine, it in your last semester. The relevance to nursing is one that people find really, really easy because everybody's topic is relevant to your own practice. So that one is pretty straightforward. How you develop your ideas is probably one of the most important things to me in terms of writing. So there's a lot of weight on how you develop your ideas. And what that means is that you are bringing in this theory from things that you're reading and you're making some position statements about it. So you're not simply reporting, so-and-so said this and so-and-so said that, or I read this or I read that. You're really making some meaning out of that in terms of what that means to you. And if you see strengths in that, if you see problems with that, and then how does that relate to the case that you're citing, that you're talking about, and then what is your thinking about that? So it's beyond a simple reporting of things, but it's really processing what you're reading and thinking about things in your paradigm case based on those readings. And we'll talk more about that as we go along, but that's a useful way to think about developing your paper. So the idea is then, if you're doing things in that way, you end up with things being very fleshed out when you're writing. So you don't have a bunch of unconnected statements. You have a lot of things that really hang together because you're tying things together and you're bringing in the readings and integrating that with the patient information that you have with this paradigm case that you know about. So you see why you have to know a lot of details? Because if you don't know the details about the case, you won't be able to make those connections. And the connections is what gives you a really fine, well-developed document and paper. And then 10% or 10 points on APA. So if you haven't paid attention to APA, you probably need to, because if you don't pay attention to the simple conventions of APA, it will put you down 10 points right off the bat. So get your style manual out if you haven't been paying attention to that lately. I know when you're doing clinical work and clinical writing, it's very different than scholarly writing. So I'm asking you to kind of step into the other mode for this course and do some writing. It will help you with your capstone project because you'll be writing it up as well. And then seminar participation, you know, of course the course is within this blended online environment, and we're looking for engagement, dialogue, evidence of critical thinking and reflection. You can read from relevant literature. I've given some examples of journals, and I've brought the books for you to look at. And I mean, I encourage that you really use the dialogue as an opportunity to put your thoughts out there to each other and then respond to each other. Okay. So there are some journals that are places to start. There are many journals that deal with patient illness experience these days. And then there are some general references depending on the focus of your paradigm case or the area that you choose to focus on with your writing. Any of those might be starting points, or we can talk and I can probably point you to some references, and I might have some on my shelf that I'm happy to share. So we can get started in that way. Okay, so to start our discussion for this week, the topics that we're going to talk about are illness stories as self-stories, and then making some differentiation between illness and disease, because that's a good place to start from. So we will start with that. I've brought copies of 2 articles that I think will get you started, and I'll give those to you in a bit here. And then Frank's chapters 1 and 2 are what we're going to cover today. And then personal meanings and social context of illness, symptoms and disorders, which is a whole language that's interesting around what people are experiencing. And then you get into Kleinman and then Morrison-Johnson, which is chapter 2. Illness is biological and social experience and the role of gender. And so there are some readings there from Kleinman and Lorber. Subjectivity and intersubjectivity is Gertis. Theories and explanatory models in chronic illness we're back to Kleinman, and there's an article by Holmes and Salibi. And illness theories is over 3 weeks, actually, because there's quite a bit that we want to cover there related to what's been written about patient experience of illness and what those theories are about. When we get up to week 8, that's March the 10th, and that's spring break, so we're not going to have any requirements or any synchronous meeting that week. And then we move into narrative, patient voice, and provider role, and your midterm papers are due that week. The role of narrative in healing practice, we're up to March 24th. And then we talk about patient voice the next week, helpers and healers, and then I'm asking you to start thinking about your own role as a provider. And healing cultures and practices, what are the challenges? And then the last week that we're going to focus on concepts and theory are to think about some next steps for what's in store for us in institutions, and where is the research needed in terms of that area. And then the last week, which will be in April 28th, will be up to the end of the course, and we'll have a synchronous session on that day, or that week anyway, where we wrap up the course and you turn in your papers and give a presentation. I've listed those books where there are lesser amounts of readings as recommended, with the idea that you may want to get together and decide who might purchase a book and maybe share resources or do something in that way. And if somebody knows they're going to buy the book, maybe they would be willing to share in terms of resources. Okay, let's start with the midterm paper. So here's the focus. You select an experience with a patient you've cared for in your practice, or an illness situation that you know a lot of detail about, either in person, or sometimes people choose their own illness. If you want to, that can be a possibility that you'd like to focus on and spend some time with in your work this semester. And then from your knowledge and experience with the situation, you develop a paradigm case or an exemplar. Can be, you'll see either of those terms, that describes the case in detail. And the definition of a paradigm case are those experiences that change our thinking in a fundamental way. So they stand out to us because we're different, we practice differently, or we think differently as a result of them. And the paradigm case then that you develop will serve as the focus of the analytic work for your final paper. So the midterm paper really asks you to develop your paradigm case. You think about something in your past, either a patient or a family member that you knew or somebody who was a friend of somebody, but some kind of case where you know enough detail that you can really describe what went on with that person's experience in their illness. And then describe it over time. So if you see the guidelines here, it says to develop your paradigm case, describe the person's illness experience as a journey over time. Think about what the symptoms meant to them. And this might not have a whole lot of meaning to you today, but it will when we start to talk about these topical areas like symptom meaning. So, you know, you'll have some conceptual understanding to bring to this when you're developing this case. So you think about the meaning of the symptoms to the person and to other people who were involved in how that experience developed for them. So would that have been their physician? Would that have been maybe a spouse or somebody like that? And I can give you an example. My father was diagnosed with prostate cancer, and we went through that with him for a period of about 2.5 years. And one person who figured really significantly in terms of how he made meaning of that experience was his oncologist, who was a very young, progressive physician who knew all the latest stuff to do and was very, very supportive and very upbeat, because, you know, he had the tools of science at his disposal. And that really figured into how we all thought about that experience for my dad and the hope that we had in the beginning, even though his PSA was off the map. You know, and on the one hand, you know intuitively with your knowledge as a nurse, that's really bad. It's a very bad indicator. But on the other hand, when you have this young oncologist who's very bright and very accomplished and who knows all the tools and says, we have several things we can do here, and he tries one and you see a dramatic decrease in a PSA just like that. So you see how his interaction with us and the way that he made meaning out of those symptoms, that the PSA was a number, but it wasn't a death sentence, even when it was really extreme. So start to be thinking about that in terms of your case and who all might have figured in. So was it somebody involved with that person's care who had a really bad experience and then brought that into that person's experience because of their life experiences? So for example, if there's a history of people who are diagnosed with diabetes in a family, and there's a family history of people having amputations because they were diagnosed really late, or they didn't get care, or they didn't care for themselves, then people automatically start making that association, and they think, well, if you're diagnosed with diabetes, then you're eventually going to end up with amputated limbs. So those kinds of things would figure into the paradigm case. So the pathophysiology, the gender, their social environment, and how all of that influenced how they were experiencing this illness. So, for example, did they have the appropriate resources, or is someone uninsured? Because that certainly has a huge difference on how they experience what's happening to them. And then what theories or explanatory models figure into the case and who used those. And we're going to spend a lot of time, three-week sessions on our schedule to talk about the various explanatory models. So you'll be looking at those and saying, was it this one or was it that one or was it one of the other ones? And you're trying to see which one gives you a way of understanding as a conceptual overlay on your case. And they will. You'll see that they fit. They help you understand some things differently with the explanatory models. So that's the midterm paper. So you turn in that paradigm case that you've developed and make some application of the explanatory models that we've studied. And that'll be the midterm. And then for the final paper, you pick that back up again. And what you want to do is take your thinking a little bit further, and you're thinking about then what kinds of things stood out to me in the course that have relevance in this case. Was it gender? I mean, you can look over the topics for the semester and see which ones of those have particular salience to you with your particular case, because they won't all. There'll be some that will stand out. So select the ones that you feel stand out and then talk about those. And then the next step is, what would I do differently, or what do I see as a result of what I've learned in the course that might make this a different experience for this patient? And how could that be incorporated into institutional practices, into how I practice as an advanced practice nurse, into interdisciplinary practices, or whatever comes to mind in terms of your thinking through. So you can make whatever kind of recommendations you think would be helpful. And then that's where we end up, because by then it's the end of the course and we're at the place where we're making recommendations to influence practice and to evolve your own practices.
So in other words, you take your midterm paper and you really grow it.
Exactly. The midterm paper is a part of the final paper. So you're moving into developing the paradigm case, applying some theories and explanatory models, the ones that you think are helpful, and then you take that and move it into the material for the last half of the course, where we're looking at what other kinds of things do we know about that we can propose that might make this a different kind of experience for this person. And then what recommendations would we make as practitioners for ourselves and for institutions in terms of how they take care of patients.
Do we have page limits on either of these?
No, I don't really give page limits because they differ depending on the complexity of the case. And I would say, your final paper will be longer than your midterm paper because you're incorporating the midterm paper into the final paper. But generally, it's about the length of a scholarly paper. I would say it's probably about 10 to 15 pages for the case. And then you build on that, so you have something that's probably 20 to 25 pages at the end. That's a general rule of thumb. You want to go for quality and being concise and succinct, and making integration when you're moving towards the end. But sometimes people start writing and they find out that the paradigm case takes quite a bit to develop when you really start to think about it and write it. And there's a lot of reflection there. Diana was asking, do you have to have access to the chart? No, not at all. I mean, you're looking back at the details that you know about that person and their care. So I'm assuming that you would know enough about their illness and the treatment that you would be using it as a paradigm case. So you do have to know enough about that, but there's not a requirement that you go back and research specific kinds of things from a patient chart. Because this is partly reflective, partly knowing enough detail as a practitioner that you can describe the case so that I or a reader would be able to understand why is this so complicated. But I would really caution you to not be worried about somebody else's writing and their example either, because what you want to do is learn to develop your own voice as the writer And that's one way of reflecting your own knowledge, but it's also another way of reflecting this patient's story. And I think you'll be surprised when you start to write the paradigm case how smoothly all that goes once you get started with it.
The example papers, though, they help me with kind of setting up the paper,
Okay.
how to go about setting it up.
Sure. Well, I'll tell you a good rule of thumb to use for that, Heather, and I tell this to graduate students all the time. If you look at the requirements for the midterm and the final paper, and you look at those main areas that says address this and address that, let those be your topical headings. And the paper really almost sets itself up. And then you're sure that you didn't forget something. So, I mean, that's just another strategy that's very simple, but it usually works pretty well. And it works the same if you have some other kind of very formal paper that you're writing, you know, where they say, here are the requirements. If you set those up as your topical headings in the paper, then you're sure that you've addressed everything. So, just a simple strategy. This is about the place where everybody sort of looks like, well, I'm not sure that I can do this. But rest assured that you can. And if you just stay with me through the course, we'll make our way through the different perspectives and theoretical understandings and all of that. And you'll probably have a pretty different perspective by the end of the course, because that's what being informed does when you start to read a little bit more widely from things that other people have written. You know, feel free to raise those questions at any point. If you have questions about your paradigm case or what you're thinking, or you want to just sort of talk that over, we can do that. That's perfectly fine. Yeah.
Do you need to buy newer editions of the textbooks? Because some of them have newer editions than what you have posted here in the syllabus. Like newer versions of the textbook, can we buy those instead of the older version?
Well, you can if you want to. I mean, the ones that are required are Frank and Kleinman, and those are classics. There may be other editions of some of the other ones, but Frank and Kleinman are classics. Well, I mean, in terms of those two books, they've been out for a long time. They were published back in the 90s. It was cutting edge at that time. And this area of knowledge has not advanced that quickly. I mean, they're really considered to be classic books by Kleinman and Frank. They've written other books. Arthur Frank is a prolific writer, and he's written other books, but not any kind of addition to that one. And you may want to read some of his other things. He's a great writer. Okay, well, let's spend a little bit of time at the end of our time together thinking about what all we're going to talk about this semester. And really the content kind of divides itself into like 3 dimensions, and you'll see that from the syllabus. The first is patient perspective, illness experiences, and the body, like symptoms, and the meaning of symptoms. So those are the kinds of things in the first part that we're going to be dealing with. And the important role of narrative, or the telling of one's experience, and why that's critically important. And some of what you'll read, our authors tell us that for people, all of us, including our patients, things become real when they're told. So that's a part of the way that we construct personal meaning around events. And then there are many things that are important related to people's social role, to their gender, because all of that is a part of experiential knowledge. So that's the first dimension. The second part of what we're going to be studying this semester in the course are theories and attributions of illness. In other words, how are people making meaning or understanding their own experience of their illness? And what can we learn about that? And those are called explanatory models. So you'll read about that in Kleinman. And then the role of pain and suffering. So what purpose do those serve in people's experience? We think about pain as something that needs to be controlled. You know, as practitioners, it's something that's not good. But there are many, many other things about the experience of that are important to people in terms of how they the meaning in their life, for example, if they get to a place where there isn't really any good answer for pain control, and maybe there's surgery, but maybe that's not a very good answer either. And so you kind of get to the end of the road where there aren't good answers. And we think about that in terms of therapeutic interventions because we have so many at our disposal in our culture and in Western medicine. We have a tremendous availability of therapeutic things at our disposal. Other cultures view all of this very differently. They don't have the technologies that we have. They don't have the resources. And they also don't have the cultural belief that people would be entitled to those kinds of resources because they simply don't exist. So there are different views about that. And then the third dimension of what we're studying has to do with professional and organizational considerations. So things like we're talking about this importance of patients' voice in all of this throughout the course. How do we learn to privilege that? Or in other words, how can we allow that to be part of our practice and be an important part of patients' care? How can that happen? What are the recommendations? What are our thinking about that? How are there ways that we can invite patients to tell their stories within our practice, and how can you do that within the constraints of practice settings that we all know? You all are in those practice settings, completing your capstone and residency projects and hours and trying to learn clinical skills. And so how in the world do you incorporate these very important things, we believe they're important, into that practice, and how does that happen? What are the suggestions and changes that would need to happen to create more healing environments for patients? And then what kinds of supports are needed for staff, practitioners, patients, everything to make that happen? And I'll give you an example of a really interesting case study that was done pretty recently by someone who's a social anthropologist, and those are the people that are interested in these kinds of problems. And he was called in as a consultant to a large oncology practice in California because they had such terrible scores on patient satisfaction related to the wait times when patients came into the clinic. And they tried everything they could do to try to fix that, and they just could not get it fixed. So patients were waiting 2 hours, 3 hours. And you know, these are people who are debilitated, they're very ill, they have family members who are transporting them because they can't drive, and you know, all of that. You can picture this. So the health center called him in and said, we just have to have a different look at this because we can't solve this problem. And what he discovered when he studied it was probably those wait times couldn't really be changed because they were due to things like some kind of major emergency had come up with a patient, and that had to be taken care of. Patients had to be transfused, they needed a change in their therapy, they had to be hospitalized, you know, all the different kinds of things that can happen in a clinic setting when you have really ill, debilitated people coming and going a lot. But what he did recognize, and this was from talking with patients, a large part of the study was talking with patients, and what he did realize was what was important to people to know was not the length of time, but they wanted to know, why am I having to wait? What's happening? And so as long as they could have some way of letting patients know, this is why the schedule's behind, or this is what's happened, the doctor's been called over here and there's a patient emergency, you know, all of that resolved itself and their scores went way up. So sometimes it's much simpler than we imagine in terms of thinking that we have a really complicated problem, or that there's something with the process here that just isn't right and it needs to be fixed. And what he found when he studied the process was as good as it could be. There are simply things that happen in those kind of clinical situations with very ill patients. They can't be avoided. There's no way you can plan for them. But the thing that was helpful was, and they learned this from the patients themselves, they just want to know what's going on. They just want to know what the reason is. And they're very willing then to understand that those kinds of things happen. It happens to someone else who's sitting beside me, it could happen to me. So those are the kinds of things that you learn with experiential knowledge when you start to do research and inquiry into different realms than what we're used to. So very much a part of care that was incorporated in that system and made a big difference in everybody's work lives and in the practice setting because they understood what was going on then. So that's just one example and the kinds of things that we're going to be studying this semester. We looked at the books. They're coming around, I think. So you see when you look at the books as they're coming around, the literature in this area is primarily in social and medical anthropology. That's where it comes from. It's not in diagnostic medicine or nursing practice in particular. It comes out of anthropology. And the professional practice literature is the other place that it comes from. So if you start looking with very open eyes at your own practice journals, you'll start noticing and seeing things that relate to patient-centered care or patient illness perspective, patient illness experience. Those are some terms that you'll see. And primarily, the literature comes from Canada, the UK, and Netherlands. Those are the primary places where you see things published. It's not quite taken hold yet in the US, although it's starting to. So two people that you'll be reading about pretty early in the course are Arthur Frank and Arthur Kleinman, the two Arthurs. And they talk to us a lot about how illness requires stories. What in the world do you think they mean by that?
Is that kind of what
Yeah, so the story is contextual and it's based on people's personal life circumstances. So while there are individual kinds of differences, there is, these two authors would say, there's collectively a need to understand those stories, to understand the importance of those stories. And Arthur Frank in particular would say, the body is the basis of the stories. So people start to think about their bodies related to illness, and as we age, there come times when your body you get up and your body just works fine and everything goes along and you go to work, you go to school, you take care of your children, you go to the grocery store, you do all the things without giving it a second thought. But when you have a diagnosis, then Judith Lorber is the person you'll read who says it's an interruption. So it stops all of that usual way that we think about ourselves because you actually experience your body in a different way. And that's a fundamental understanding yourself that we don't understand as health professionals. We don't even go there. We're looking to make a diagnosis based on someone's symptoms, and then people have, along with this diagnosis, really had their lives interrupted. So you see how different that is. It's a very different way of thinking about things. So if I'm a patient and I go in and my practitioner is trying to tell me what I should be doing to pay attention to my hypertension or to manage my blood glucose, and I'm thinking, well, the main thing for me is I have small children and somebody's birthday is coming up next week, and so how are we going to manage this issue of a birthday party and cake and all of that sort of thing, because we always celebrated those as a family, and now what are my children going to think, and do I have to change everybody's eating patterns because of me and this illness, and what does that mean for everyone else? So, I mean, it just sort of reaches out in all different ways that you wouldn't necessarily expect. Judith Lorber is the person who says that, life as we know it is interrupted when people get a medical diagnosis. And she says, I mean, it's pretty serious the way she talks about this. She says, actually, we lose our life map. So the way that you've thought about your life sort of going along in the direction that it was going has stopped. And you don't know what the map is right now. You don't really know what's ahead. It might not be something that you're very hopeful about. You might be pretty worried based on all these other things that your family knows or that you know. And that this loss of life map and destination is not medical symptoms. It's not anything that has to do with your blood sugar level or your blood pressure reading or your BMI or any of those kinds of indicators that we use to make judgments about patients or make recommendations to patients when they come in. So, I mean, have you ever thought about that? If you're doing an assessment with a patient, would you ask the question, well, you know, what's the interruption in your life from this diagnosis and what's happened with your life map?
They would look at you and be like, well.
Yeah. It would get a pretty strange response to that. It would get a pretty strange response.
But I think with cancer patients, you kind of get the, you know, they tell you how that it's interrupting their life more
Sure.
than just medical patients.
Sure. Yeah, I mean, I think in terms of that journey, there's been a lot of different ways that certain groups of patients, because of the kinds of experiences they have, that comes out a little bit more.
Maybe that fear of life interruption, it can explain somewhat why people ignore their illness experience, their diagnosis.
Or won't go for preventative.
We're not asking the right questions. We're making assumptions about people being compliant or not compliant or adherent or whatever term you want to use to things that seem very simple to us on the surface, but yet there's some complex something going on there that would really help patients if we understood that. If we understood that routinely and made that a part of our care and made that a part of how we interact with patients. So some of the authors that you read will actually suggest, here are some questions that would help us get to that. And it might be something like, if you're doing an intake interview, one of your questions might be something like, so what's this been like for you? It's very open-ended. I mean, it's a very different question than saying, how are your blood values? Have you been checking your blood, you know, every morning? Or what are your questions about insulin administration? Or show me that you can do that. But when you ask that question, what's this been like for you? Then that opens the door for people to tell you about their experience, and then that's how you get to things like that. So the other thing that these authors are saying is the scope of our professional practice should include those kinds of understandings. So we should be thinking about that. And that's help patients rethink their own world. And that sounds really esoteric, but when you think about these two examples, it's really a pretty clear way of illustrating that concept. So that part of the practice is not just diagnosis and all of our expert knowledge around what we know with medical science and nursing interventions and drug therapies and referrals to different disciplines and all that sort of thing, but that it's a much more intimate kind of thing where you're really helping that person based on your questions, based on your presence, based on your giving them an ability to be able to provide some narrative that's essential for them to start to experience what that's like for them. So that's a first step. And, you know, the whole, just when you're thinking about narrative and the use of stories, there's been a lot of that in the popular literature lately. And I guess I would caution you that this is a very different look. This isn't just let's all sit down and around the table and tell each other something about something. This is a very focused way of asking patients that's a part of practice. So it's not a casual, you know, belief system that we all believe it's good for everybody to tell certain things about certain things. It's a very focused kind of practice. And let's see what else. So if you think about it over time, stories have been used a lot in healing practices, in myths, in folk tales, in life histories. I mean, you'll see it all around all those kinds of things. And it's been used to examine folk explanations of illness, which you hear some of that about our Appalachian culture, and certain kinds of concepts like fatalism and things like that, curing rituals, practical strategies for seeking care for illness, and then interactions between healers and patients. So all of that is in the history of narrative. What it allows us to do, and this is what the writers are very clear about and want us to try to get an understanding of, it accesses events that you can't witness. So it allows you, when people can tell their stories, when they have an opportunity to provide some narrative and to talk about what's happening to them with a chronic illness. It allows us as practitioners really a very privileged place because it allows us to have access to information that you normally would not have. So, if we know that, there's been some movement now to move towards a more conscious strategy to elicit people's stories as part of professional practice. And that's where we're focused on towards the end of the course, where we're going to be reading some of those things, some of those recommendations, and you all will have a chance to look at your paradigm case and make some recommendations about what you think might move people towards understanding and healing and some human connections. And then the other part to think about is, and you'll see this when you start to think about your paradigm case and write about it, that this whole issue of making meaning is not easily done. People struggle with it. They struggle with the whole idea of putting time and attention to themselves. They struggle with things that they already have views that really aren't appropriate for them to be worried about. They should be worried about something else, not their illness. So it's very much something that is a struggle, and it's not easily done for patients. So it requires some thinking and some skills and some competence on our part as practitioners, and that's the reason that we're introducing it towards the end of your doctoral work so that you can give it some thought as you're thinking about your own role and what that will look like and be like as a doctorally prepared nurse. So I'm really just looking for you to begin to integrate. This is your last semester in your program, so show me what you got. Integrate your thinking and post some nice thinking, some thoughtful questions. Quantity is lesser of importance than quality. So we have to have a little bit of an opportunity to let the discussion form itself based on your participation. And that's how I like to do discussion forums. So we'll try that and see how that works. If that doesn't work, we'll do something else.
So is the midterm paper due on the 17th, March 17th?
Yes.
Okay.
And you can put that in the Dropbox in D2L. So I would say relax into the course a little bit if you can. I know it's a busy semester. And I know you have a main goal in sight, and it's coming for most of you at the end of this semester. So use the course as an opportunity to do some thinking and learning in an area that's going to complement your practice, that you probably have not done much thinking, if any, about up to this point. And just stay with me, and it will go well.